He is joining. It may take a few minutes, but never mind.
Anirban will start in around 7:05 maybe or 7.
No, we'll start in 1 or 2 minutes.
Still there people joining.
Yeah, people are joining, so we'll start.
Maybe 7:05 or 7:10 maybe.
Yeah, good evening, Shorinda.
Okay, Sauran is in the vehicle. So good. Hi, good evening, Sauran.
Yeah, good evening.
Good evening, good evening. So we'll start in maybe 1 or 2 minutes on the call of
No, it's,
Anirban
yeah.
whenever Anirban decides.
Vinay, can you let Jaiprakash inside the panel too? He is raising his hand. I can see.
There's no sound, Vinay.
Hello,
Not
friends.
hearing it.
Welcome to this brand new episode of the GICS Rapid Journal Review. The conventional management of comatose patient of poisoning is known to all of us. But who goes beyond the convention? Yes, that's what is pointed in this new trial published in JAMA, a randomized controlling trial where a non-conventional way of managing comatose patients of poisoning, acute poisoning, by withholding intubation has been studied at great length. Today, we are going to discuss this study, and to present this study will be Dr. Arjun Talapatro, a DRNB trainee from Amri Manipal Hospital, Dhakuria. Welcome you, Arjun. And who will be moderated by the senior consultant, Dr. Shashwati Sinha from the same hospital. Welcome you, Dr. Shashwati, in the journal GICS Rapid Journal Review.
Thank you.
We also have an expert panelist, Dr. Shorin Paja, the head of critical care and internal medicine from R.N. Tagore Institute of Medical Sciences, Kolkata. Welcome you, Dr. Shorin Paja.
Yeah.
And of course,
Good evening. Good evening.
and we have our regular panelists, Dr. Pradeep Rangappa, and we will be joined shortly by our other regular panelist, Dr. Ajit
Dr.
K.
Jaiprakash also has joined
Bangalore.
with us.
And we have also amongst us today, Dr. Jaiprakash, who will also be sharing his views as and when time comes. But before that, first of all, we are going to hear a brief commentary on the neurological manifestations of acute poisoning as a prelude to this journal club by Dr. Pradeep Rangappa. Pradeep, you can start sharing.
Thank you. Vinay, you can start sharing.
Yes, sir.
Good evening, friends. So I'll be giving a very brief overview on acute poisoning neurologic manifestation. So this is in the context of the journal presentation being made on non-invasive airway management in comatose patients that came up in JAMA that will be discussed by subsequently after this talk. So I wish to acknowledge my colleague, Dr. Bhavya, who helped me develop this content. So it's a brief overview on neurological manifestations of acute poisoning. So if this possibly asked as a question in DNB, some sort of a clarity is needed as to how we would approach this poisoning. And it is good to know what sort of poisonings that we can do a non-invasive airway management. Many a times we have patients coming with overdose with say diazepam poisoning or benzodiazepine poisoning or even alcohol intoxication. So GCS may be 6, 7, but we not necessarily we would jump and intubate. So because most of these toxicity we know are reversible and possibly you can wait and they would recover. And this trial was mainly to look into that aspect. So I'll just take you through a brief overview on the type of neurological manifestations that happens with this sort of poisoning. So when we talk about poisoning, we have to categorize them into few categories. So when we talk about the categories or the broad dimensions of poisoning, so one you would be obviously looking at the poisons or the drugs. I would use the word drugs causing sedation or obtundation or stuporous. Then the second is the drugs that can cause agitation because all these are neurological manifestations. And the third important aspect is the drugs that causes seizure in a patient. So there are multiple drugs that can cause seizures and neurological manifestations. And the fourth interesting category is the drugs that cause movement disorders or akathisia. And it is said that any patient who is on medications, 5% of the akathisia, so 5% of the drugs can cause akathisia. So it is a very common entity that is described. So anyone who is on any drugs, around 5% of most of the drugs can lead to akathisia. And there are certain conditions which lead to encephalopathy. So this is how one would possibly categorize the neurological manifestations caused by a drug or the poison. So any poison that you look at can act on either central nervous system or on the peripheral nervous system. And there are certain drugs which have a variable penetration in the blood-brain barrier. So most of the toxins that we talk about have a variable penetration through the blood-brain barrier, and the manifestations can be quite multifold, and it is very variable. So it is very hard to determine which drugs are more blood-brain barrier penetrable or less penetrable. And there are certain drugs which act at the neuromuscular junction, and most of you would know that OP poisoning, which typically we deal with, tends to act on acetylcholinesterase, and there is more of pooling of acetylcholine levels at the neuromuscular junction, leading to the weakness, so on and so forth. So these are some of the structural dimensions, the way these drugs act. So central nervous system, peripheral nervous system, neuromuscular junction, and variable penetration into the blood-brain barrier. So when we look at the classification of the drugs, so as I said, we look into five major categories: drugs that causes sedation or obtundation, the drugs that cause agitation, involuntary movement, seizures. So based on this, one could classify the drugs into various categories. So one important is anticholinergic. So here, most of these drugs tend to cause delirium in a patient, and antihistamines is one category where chlorpheniramine maleate, which is commonly used, diphenhydramine. TCA is an important anticholinergic drug which can lead to neurological manifestations, amitriptyline, so on and so forth. And antipsychotics, which we tend to use often in ICU, haloperidol, thioridazine. So these are some of the drugs which can cause neurological manifestation. And antiemetics like chlorpromazine can lead to extrapyramidal symptoms. And so these are the common drugs which can lead to toxicity and lead to neurological manifestation. So there are cholinergic agents, and OP poisoning is one which we commonly deal with. So dimethyl, and there is a separate video on that you can go and watch. So dimethyl compound and diethyl compounds are the two broad categories of OP. Most severe manifestations are caused by dimethyl, and malathion and xanthine come in the dimethyl group. Then there are now gas like sarin and VX. So then you have the third category, which is opioids. So and the recreational drugs that are used like heroin, codeine, and morphine are naturally occurring opioids. And there are opioid-like compounds like clonidine and clonazepam. So and these cause typically sedative effects. And cholinergic compounds cause more of agitation, and anticholinergic cause more of delirium and stupor sort of a situation. Then you have this sympathomimetic agent, which causes more of agitation, like adrenergic agents like cocaine, amphetamines, and phencyclidine. And these are used as recreational drugs, and they cause sympathetic hyperactivity, and more agitation would be the manifestation of these drugs. Then there are these xanthines like theophylline and caffeine, which again causes agitation. And there are atypical antidepressants like neuramine reuptake inhibition. Like these are the older drugs you would have heard of, venlafaxine, trazodone. So all these can cause agitation. So this is the fourth category of drugs. So we spoke about cholinergic, anticholinergic, opioids, sympathomimetic. Then there are these sedative hypnotics which causes sedation. Alcohol can be ethylene or methylene glycol or ethylene glycol or ethyl alcohol or methyl alcohol. Barbiturates, phenobarbital and pentobarbital. And we do see often sometimes toxicity with barbiturate, which come now and then. Then benzodiazepine is the most common drug toxicity one would possibly see in intensive care. So it can be any of the benzodiazepines, and so lorazepam, diazepam, midazolam, so on and so forth. And miscellaneous drugs, there are the gamma hydroxy butyrate and baclofen. So these are the categorization of the drugs, acute poisoning causing neurological manifestations. So you can, for all the DNB trainees, if this question is asked, you can categorize as cholinergics, anticholinergics, then opioids, sedatives, and sympathomimetics. So these are the five categories that you could put things in. So the common manifestations of CNS toxicity, as I said, agitation is the commonest one that they manifest. Then once it is severe form of agitation, they can go into delirium, and then they go into stupor, and they can go into comatose. So this is a typical spectrum we see in ICU when someone comes with toxicity. Initially, they can have a state of agitation, they move to the delirium, becomes tuberous, and then more coma. So there are distinctive group of drugs that causes seizure. So you can use this mnemonic. You can remember this drug by using this mnemonic Otis Campbell. So O stands for opioids, so they can cause seizures. T stands for theophylline and tricyclic antidepressants, which cause seizure. I stands for insulin, means hypoglycemia or INH can cause seizure. S stands for salicylates. C is cocaine, cyanide, or carbon monoxide. A stands for amphetamine or anticholinergic. M stands for metaldehyde. And P is like carbapenems, imipenem is known to cause seizure disorder, and sometimes levofloxacin also is touted. So any drug can cause. So you can remember as penems. And B is barbiturates, and E is ethanol. So L is for lead and lithium. So this is a very easy mnemonic to remember. Otis Campbell. These are the groups of drugs that can lead to seizure disorder. So, so it's just a broad overview to try to remember and categorize the drugs that causes neurological manifestations. And this is a distinctive group of drugs that can cause seizure. So very important to know. And when we have a patient with the drugs causing seizure, generally the pathognomonic feature is there is an imbalance between the neurotransmitters within the brain. There's an imbalance of glutamate and gamma aminobutyric acid. And typical manifestations due to imbalance lead to generalized tonic-clonic seizures. And tricyclic antidepressants, they act on the sodium channel in the brain and they lower the seizure threshold. So that is the way they cause seizures. And cyanide causes cellular hypoxemia and oxygen consumption gets reduced, and that leads to seizures due to cyanide. And the theophylline and caffeine, they act on the adenosine receptors and they can cause refractory seizures. So these are some of the molecular mechanisms as to how seizures are caused by the some of the key drugs. So TCA, which we tend to see, they predominantly act on the sodium channels and lower the seizure threshold. Theophylline, we used to use a lot of deriphyllin and so on and so forth for COPD. They act on adenosine receptors and can cause refractory seizures. So these are some of the mechanisms, the way these drugs cause seizures. So the other group that we saw, so we spoke about sedation, we talk about agitation, we spoke about seizures. Then there's an other entity called encephalopathy. Encephalopathy is typically caused by other organ dysfunction having an impact on the brain. Typically, you would see hepatic encephalopathy. And this can be, we are talking about acute poisoning, like if you have a paracetamol poisoning, so it would act on the cytokine P450 in the liver and lead to accumulation of N-acetyl paraquinone imine, which leads to encephalopathy. So I'm sure all the listeners would know paracetamol can lead to liver failure and encephalopathy can ensue. So any end organ dysfunction can have an impact on brain and encephalopathy can ensue, and this can happen even in the drug toxicity. And someone who is a cocaine addict or a heroin addict, where they do the snorting, so this can lead to leukoencephalopathy, and there can be increase in the lactate within the brain that leads to encephalopathy. So we are only talking about drugs causing encephalopathy, and if we talk about encephalopathy, it is secondary to certain organ dysfunction. So in paracetamol, it's the liver dysfunction, and in with regards to snorting of cocaine, it is due to leukoencephalopathy. When it comes to alcoholism, it is due to thiamine deficiency. So in alcoholism, there is a thiamine deficiency which leads to Wernicke's encephalopathy. So this is some of the conceptual understanding as to how encephalopathy happens due to drug toxicity. And movement disorder. So a lot of drugs can cause movement disorder. Just pay little attention to that video there. So that is an akathisia. Akathisia is a repetitive movement of certain motor activity. And as I said, 5% of any drug can lead to repetitive movements and movement disorders. So the movement disorders can be dystonia, and I'm sure many of you would have seen dystonia, which can happen due to certain antiemetics like chlorpromazine, so on and so forth. And akathisia, the commonest drugs that are implicated are tricyclic antidepressants. The video you saw is the typical akathisia, where there is repetitive movements. It can be secondary to tricyclic antidepressants, monoamine oxidase inhibitors, and SSRI, selective serotonin receptor uptake inhibitor or atypical antidepressant. So these are the ones which can lead to akathisia. So remember, akathisia is something which is commonly seen where there is repetitive motor movements and it's the restless movements that can happen due to the drugs. So that is about the movement disorder. And stroke. Stroke is also a manifestation of acute poisoning, and this can happen in someone who is taking cocaine or snorting cocaine. And it can happen due to the recreational drugs, overconsumption of recreational drugs like LSD, lysergic acid, or amphetamines, and its derivatives. So, stroke also is one of the manifestations of acute poisoning. So, and how about CNS infections? CNS infections can happen, especially when there is an infective endocarditis in an IV drug user, or there can be meningoencephalitis or cerebral abscesses that can happen due to the underlying infective endocarditis in IV drug user. So that is the sort of a conundrum that tends to happen in acute poisoning. So someone who is a drug abuser can develop endocarditis, and that can lead to systemic embolization and lead to meningitis and cerebral abscesses. So that's in brief about the neurological manifestations of acute poisoning. Predominantly, if you look at neurological manifestation of acute poisoning, it is all the psychotropic drugs that have a major role. And for all the trainees, you can categorize those drugs as cholinergics, anticholinergics, opioids, sympathomimetics, and anti-seizure medications. And the way you would categorize these neurological manifestations is sedation, agitation, seizure, and movement disorders and encephalopathy. So those are the five categorizations that you can do. And when you have any of these manifestations, obviously you need to have a differential diagnosis as to what are the other possibilities of what are the other causes you have to rule out before you attribute it to the drug toxicity. For that, most of the ICU trainees, you would know that for all my ICU trainees, I keep telling this mnemonic AEIOU IPSI. So, so A stands for alcohol arrhythmias, and E stands for epilepsy or electrolyte abnormalities. I is infection, O is overdose or hypoxemia, U is uremia, metabolic, T is toxin trauma, I is insulin hypoglycemia, P is psychosis, S is stroke, E is endocrine. So this is the typical differential that you would think in any obtended patient before you attribute it to toxin. You have to rule out all these other possible causes which may be confounding the underlying sort of a diagnosis. So that's about it. So this is a very brief overview or a prelude to this journal presentation as to where the next speaker will be talking about non-invasive airway management in drug toxicity. So thank you one and all. So I request all the listeners to present their valuable work to Journal of Acute Care. You can visit my website www.pradeepanwappa.com to read to this lecture. Thank you. Thank you one and all. Thank you. Thank you, Vinay. You can stop sharing.
Thank you very much. It was a nice prelude, and thank you for the commentary. And now the stage is set for Arjun Talapatra to present today's journal club. And here it is, Talapatra. You can start sharing your screen right now.
Good evening, sir, and good evening to all the panelists. Coming to my journal, this was a randomized clinical trial which was published in JAMA, done by a group of French investigators. So before I go into the details of the trial, let us talk a little bit about what was the need or the context behind this trial. So as we know, patients who have a decreased level of consciousness are at a risk of aspiration, which often leads to severe complications, including respiratory distress, pneumonitis, or a pneumonia. Now, in contrast to trauma, where there are more clear guidelines, the decision to intubate patients with suspected acute poisoning is often not clear. And there is a lot of debate around the GCS level and when exactly these patients should be intubated, if at all. The expected benefits of intubating these patients is to limit the aspiration of stomach contents and thereby preventing a subsequent pneumonia. However, intubation itself may lead to these problems, causing an aspiration and a pneumonia. The additional risks of intubation include a hemodynamic instability, hypoxia, difficult intubation, and dental injury. Despite these trade-offs, there is no good study till now before this which gave us a high level of evidence to guide decisions about intubating such patients. We have observational data, some of which suggested that early intubation may reduce the risk of aspiration. However, there was other data which showed no difference in the risk of aspiration or death between patients who were intubated and patients who were not. So to address this knowledge gap, this trial was done, which tested a strategy of withholding intubations in patients with coma against one where intubation was done whenever it was deemed necessary and was left to the discretion of the physician. So this was a multi-centered, unblinded, randomized parallel group trial. It was done at a total of 21 sites in France, including 20 emergency departments and 1 ICU. Patients were randomly assigned in a 1:1 ratio to either the control group or the intervention group. Now, in the intervention group, intubation was withheld till an emergency intubation criteria was met. However, in the control group, the decision to intubate was left to the discretion of the emergency treating physician. So in the intervention group, the patient was only intubated when they met these following criteria: either a patient who was developing a seizure, a patient who developed a desaturation below 90% despite oxygen supplementation by nasal cannula, a patient who started vomiting, thereby increasing the risk of aspiration, or a patient who developed hypotension despite adequate fluid resuscitation. For the subsequent 4 hours or up to the point where the patient had recovered a sufficient level of consciousness, that is a GCS score greater than 8, whichever came first, the patients were closely monitored in the emergency department. And after this period of 4 hours was completed, or the patient had but the patient's GCS had improved to more than 8, the intervention was defined as complete and the patient was maintained according to routine practice at the discretion of the emergency physician. And it is important to note here that in both the groups, when intubation was performed, the physicians were recommended to follow the guidelines of the French Society of Emergency Medicine for rapid sequence intubation. The study included adult patients who had a clinical suspicion of acute poisoning and a GCS of less than 9. It is important to note here that a suspicion of acute poisoning was good enough to include patients in this trial, not necessary that they had to confirm the acute poisoning. And patients were excluded if they were pregnant, if they had an immediate need for intubation. They were excluded if there was a suspicion of poisoning with beta blockers, calcium channel blockers, and ACE inhibitors, because probably the threshold for intubation in these cases would be lower due to the severe hemodynamic instability. And also, if they were intoxicated with a single substance to which a potential reversal agent was available, then the patients were excluded from the study. So, a total of 237 patients were randomized. 119 were randomized to the restricted intubation protocol group and 118 to the control group. And finally, in the PERT protocol analysis, there were 112 patients in the restricted intubation protocol group and 107 in the control group. Just going into a little bit of details about the baseline characteristics, around 60% of patients were male in the restricted intubation group and around 64% were male in the control group. Most of the patients were young. So the average age was 33 in the first group and 34 in the second group. Majority of patients were included in the emergency department and around 37% were included in the pre-hospital setup. And almost no patients were included in the study in the ICU. Both the groups had a similar incidence of tachycardia and a similar blood pressure, and also a similar incidence of decreased respiratory rate, which could be due to the effect of opioids or benzodiazepines. Both patients had similar peripheral oxygen saturation and a similar median GCS score. The body mass index was also matched. And it is important to note here that the most common toxin that they encountered in this study, around 65%, was alcohol, followed by benzodiazepine, followed by gamma hydroxybutyrate, cocaine, opioids, amphetamines, and cannabinoids. The primary outcome was a hierarchical composite endpoint of in-hospital death, length of ITU stay, and length of hospital stay. The secondary outcomes that they looked at were individually each component of the primary endpoint along with the proportion of patients who received mechanical ventilation until hospital discharge or at day 28, the proportion of patients who were admitted to the ITU, the proportion of patients who developed a rapid onset pneumonia, and also the adverse effects resulting from the intubation. Now, the primary outcome, one of the primary outcomes was ITU mortality, but no patient died in either group. And the intervention strategy of withholding intubation resulted in a lower median length of ITU stay as well as a lower median length of hospital stay. And the composite primary endpoint was also improved in the intervention group compared to the control group. I will come to the details in subsequent slides. So this was the win ratio, which was calculated to be much higher in the intervention group. Now, how exactly did they calculate this win ratio? So what they did was they divided the patients into pairs and they compared the two patients. So because no patient died in either group, in terms of deaths, all the patients were tied. So for instance, if patient A survived when patient B died, then patient A would be said to have a win and patient B would said to be have a loss. But because no patient died, they could not differentiate the patients on the basis of death. So they had to come to the second outcome, which was the length of the ITU stay. So here they found that here when a patient had a lower ITU stay, when patient A had a lower ITU stay than patient B, patient A was said to have a win and patient B was said to have a loss. And if they could not differentiate the patients on the basis of the length of ITU stay in days, then the patients were said to again be tied. So then out of all the patients who were tied by this, they looked at the length of hospital stay. Again, if a patient had a lesser hospital stay than patient A had less hospital stay than patient B, patient A was said to have a win and patient B was said to have a loss. So overall, there was a much higher incidence of wins in the intervention group than in the control group, around 64.6% in the intervention group. And they also calculated the win ratio, which was the percentage of total wins divided by total losses. And the win ratio was also much higher in the intervention group, which is how they proved the superiority of the intervention group. The secondary outcomes that they looked at, there was a lower percentage of patients admitted to the ICU in the intervention group, 39.7% versus 66.1% in the control group. And the intervention group also received mechanical ventilation less often, only in 18.1% versus 59.6% in the control group. And also the intervention group experienced fewer adverse effects resulting from the intubation, 6% versus 14.7%. Coming to the outcomes, as I said, no patient died in either of the groups, but there was a lesser incidence of patients in the restricted intubation group who required an ICU admission versus the control group. Also, there was a reduced length of ITU stay in the restricted intubation group versus the control group, and also a reduction in the hospital stay in terms of the number of hours that the patient was required to be kept in the hospital. And also these patients in the restricted intubation group received less mechanical ventilation than patients in the control group. These patients also had a lower occurrence of pneumonia. So contrary to popular belief, which was thought to, popular belief tells us that patients who are not intubated, patients of acute poisoning, are supposed to develop pneumonia due to aspiration. But this study actually showed that not intubating these patients actually protected them from developing pneumonia, and probably the process of intubating them caused aspiration more often, causing a higher incidence in the occurrence of pneumonia. And also the adverse events resulting from intubation was higher in the control group versus the restricted intubation group. So coming to the discussion about the trial, in the absence of any death occurring in this trial, the observed differences in the median length of ITU stay were subsequent to the reduction in ICU admission in the interventional group. More than half the patients were intubated in the control group. This illustrates the clinical equipoise around the decision to intubate such patients, and it illustrates how it is often very difficult to decide whether the patient should be intubated or not, which is why it is important to come up with guidelines regarding this. And there are still many caveats around the use of GCS to identify study participants, though this study relied exclusively on GCS. So that could have been a problem with the study. And though previous studies, a lot of previous studies and a lot of previous data that we have included patients who underwent gastric evacuation, especially patients who had organophosphorus poisoning. However, in this study, no patient was treated with gastric evacuation or activated charcoal because the toxins in this study was very different from the toxins primarily found in other parts of the world. And this could also have affected practice, also have affected the results of this study and possibly extrapolating this study to other regions of the world. Now, this study does have a lot of strengths. Firstly, it is this is the first randomized trial which compared a conservative strategy of withholding intubation versus routine practice. The primary outcome here addressed more patient-centered endpoints, while prior work mostly looked at only the risk of aspiration pneumonia. So this was the first study which looked at probably more important patient-centered endpoints like ICU stay, length of hospital stay, as well as mortality. There was also a significant reduction in the risk of pneumonia, which suggested that when patients were intubated for airway protection to limit the risk of aspiration, this may itself paradoxically increase the chance of the patient developing a pneumonia, which was a very important take-home message from this study. The study, however, does have its share of limitations. First of all, this was an unblinded study because it is not possible to blind investigators to this study. The primary outcome that they looked at was the composite of death, length of ICU stay, and length of hospital stay. However, there were no deaths in the study population, and 1 out of 5 patients did not require an ICU admission at all. So this again could have affected the results. Some patients were intubated in the emergency department and some in the pre-hospital setting. So the settings in which the patients were intubated could also have affected the study results. And another important thing to note is that patients were included only if there was a suspicion of acute poisoning, which was not necessarily ascertained in all patients. And also the study did not record the use of UG or radiolaryngoscope during the process of intubation. So these were the limitations with the study. So to conclude, amongst comatose patients with a suspected acute poisoning, according to this study, a conservative strategy of withholding intubation was associated with a greater clinical benefit for the composite endpoint of in-hospital death, length of ICU stay, and length of hospital stay.
Thank you. Thank you so much, Arjun. You have very nicely presented this study. And before I move on to the question answer round, I would just request Shashwati that if she wants to add anything more to what Arjun has already presented, I surely she can do that in 2-3 minutes. Yes, Dr. Shashwati.
Thank you. And I think this is quite a landmark kind of trial in the sense that by conventional belief, we have always been, and in fact, all over the world, GCS is what is taught to us during our training, that if the GCS is less than 8, then intubate. And that is often the way to go. That is what is recommended. But as we also need to understand that all toxins are not the same. All kind of emergency situations or the medical setup may also be different. So again, what could have been done in a French ICU or in a French emergency department may be difficult to extrapolate in our settings. Also, the kind of frequency of what kind of toxins they dealt with may be quite different from the kind of toxins which may be prevalent in our scenario. As well as I think they monitored these patients for about 4 to 6 hours. So what happened later on may also be, because there may be certain drugs or toxins which might have a longer duration of action. So if the kind of toxin is not known, which was very, very well known in this kind of a study, so how would our practice be different in those kind of situations? So those are the things I think would need to be kept in mind. Otherwise, this is really a path-breaking kind of a research, especially in resource-limited settings. I think avoiding an ICU admission and intubation, I think, and also may prevent an infection, which is a very important aspect which they have studied. So I think these would be my points.
Absolutely, absolutely, Shashi. There is absolutely no difference. There's no doubt about the fact that this is indeed a landmark study, a path-breaking study for the condition that it is going to think something different from what has been conventionally taught, and also that the ethical committee was supportive enough to allow this study to continue. But I would first like to ask our expert panelist, Dr. Shoran Paja. Dr. Paja, are you there? Dr. Shoran, please, are you there? Well, I will ask this question to Dr. Shashwati only till the time Dr. Shoran takes over. That first things first, when you see this study from a neutral standpoint, and you see that the exclusion criteria includes all cases with immediate intubation, all patients who are likely to have received any cardiac drugs with poison can have a cardiac effect, all we have a single poisoning with a single drug which can be reversed by an antidote. So don't you think that that takes a sizable number of patients away from the study? And that size is also important because this study remains invalid for such patients, and they form actually a large chunk of the population.
Absolutely. So also the knowledge exactly of what kind of intoxication the patient has come with becomes very important. And a lot of times in our scenario, we may not have an idea about the kind of toxin. So if the patient has a low GCS and we have no idea, or the bystanders have no idea, so it might be a little bit difficult. That is in the first place. Second, the intensity and the kind of manpower required to monitor these kind of patients, especially with an unprotected airway, that will be a major consideration.
That becomes a big challenge. That becomes a big challenge.
Emergency department, it will be a big challenge.
Very true, very true. And if you look into the study, you find that there were 18 ICUs where it was the ED in the hospital setting. Only the patients were allowed, and in 18 and in some it was allowed in the pre-hospital scenario in 4 more. I think that's the number, or it may be reversed. And the manpower subsequently changes between the two places, because if a patient is intubated in a pre-hospital setting, obviously you won't get the kind of expertise and support that you get, and there can be risk of I move. Is Dr. Pradeep there?
Anirban, I'm there. I'm here.
Pradeep, I just want to ask you one important aspect of the study which needs to be highlighted here, is that when you choose a composite outcome, which includes death, which in the top of in the hierarchical order, and you find there is no death in both the groups, what relevance does that composite outcome retain? Because that composite outcome is measuring only 2 aspects which are lower down, and your primary main thing has been eliminated.
No, I think that was a very intriguing aspect of this study, Anirban, which authors also do make a submission in the discussion, as the presenter mentioned, because composite endpoints is something that we have always said ICU studies should look at, based from all the cardiology studies. If you look at any cardiology studies, they very cleverly take the composite endpoint of acute coronary events, so on and so forth. Here they took, but they failed miserably, because the reason is the authors themselves say that mortality was not identified in any of the patients. So that will pretty much eliminate that value of that composite endpoint, because it was only the length of stay at the end of it, Anirban, which our presenter also did mention. So it was only the ICU length of stay, which is like a secondary outcome. So the composite endpoint, although very cleverly they incorporated, but at the end of it, it did not have any value. Is my thoughts on this. So you're
absolutely right. Absolutely, it didn't add too much of value, and probably the composite endpoint, which tries to reflect that each of the component has its own share, that the relevance is lost when one fails. Well, Jayaprakash, I want an answer. Want you to answer this important one, since they have calculated something unique called the win ratio, and they have come out with a magic pair of 12,444 or 444 pairs in a group of these patients, this 224 patients divided into. Now, how valid is this win ratio? In which kind of studies do you think? Because this is something which is not too common, and which is not too common even when composite outcomes are chosen. Yes, Jayaprakash.
Sir, if you will see their analysis, so what kind of a statistical analysis they use? For primary analysis, they use that Finkelstein field method.
Correct.
One thing. Second thing, if you go through, because I opened that, I shared that paper in many groups. With your that journal review, I sent paper in. If you will see the
we have gone through that, and later on the mental hassle also.
There are many latches in this paper. First, I would like to exclusion criteria. Second thing, who will decide that?
I want you, Jayaprakash, to answer the specific question about win ratio. What is its importance of win ratio? Is it likely to be more useful in such kind of studies? If it is so, why it is not commonly used in other studies which use composite outcome?
Yeah, I was coming on that point only. I don't know why they used win ratio, because their primary objective was to calculate the death, and in both group it was. So that they use because if you will read the protocol, I don't know how many people read that protocol. The link of protocol was there. If you will see that, it was mentioned clearly they used win ratio incorporate with the death ratio. You will see in protocol. One thing is that. Second thing, one by one, because I read 2 times this paper and it was very interesting. But there are many latches in this. If you will see that the secondary endpoint you were discussing, because primary endpoint there was no differences. Secondary endpoint was there, the length of hospital stay, ICU admission. See, who decided to put the patient on intubation? The primary physician who was patient land up in those emergency department. They decided that, but what was the protocol for the intubation? It was not clearly mentioned. One thing. Second thing is that if you will see that if you will intubate any patient, definitely you have to put patient on sedation. There are many hemodynamic abnormality or fluctuation, so you may need to admit patient in ICU. So definitely your secondary endpoint will go up. That means once patient will land up in the ICU after the intubation, there will be hemodynamic abnormality, and the length of hospital stay and ICU admission, it will increase. One thing. Second thing, now come to the table 2. I opened that in other systems, sir. What I was seeing that if you will compare with the hemodynamic parameters, so those control group, that means those patients who were intubated, there was the fluctuation of hemodynamic abnormality. So you may easily get it that. Second thing. Third thing is that, sir, I was third thing was that the what I was observing.
Well, we will come to the remaining portion in the subsequent question.
Okay,
now we want to move into the other important questions too. Now, is Dr. Shoren, are you there? Dr. Panja, please. Well, I will move on to Shashwati once again, since we are and Vinay, can you please add Shulagna into the main panel group, please? She is there in the attendees. Dr. Shulagna and Dr. Manju Matthew. Vinay, if you are listening, you can please do. Well, I'm going to Shashwati that if you see the profile of the patients, you will find that around 79% of the patients were actually alcoholic, and they have been categorized as acute poisoning, and the period of observation is 4 hours, after which, and by which a time The alcohol must have been washed away and much of them could have recovered. So now don't you think that that is in conflict with the objective of the study, where the primary purpose was to draw to the fact that the kind of poisoning, the pneumonia or the risks that are associated and the kind of intubation can have its effect? Yes.
Absolutely. In fact, one of the exclusion criteria was if there was any toxin which could be easily reversed. So that was out. So probably they were talking about benzodiazepines and opioids. So even alcohol might fit into that kind of a criteria. But the majority of the patients, I think 67%, had alcohol intoxication. So when you have a major part of the population who are intubated, or who are a part of the study population, that might have definitely interfered with the results to some extent.
So another important point which arises in the context of this study is that when we talk about GCS and we try to figure out that how much correlation does it, I want to ask Dr. Shulagna, and I will ask the same question to Dr. Manju also. Both of them have joined as panelists. Shulagna, can you hear me?
Yes, sir.
Please. Yeah, when it comes to the GCS scoring and we try to figure out that how much of the patients would develop pneumonia subsequently or not, and we know that the period of observation is only 4 hours. How valid is GCS to decide an outcome as important as pneumonia?
Sir, I think the most important thing here is GCS. For prevention of aspiration pneumonia, GCS, we have taken it as a standard for deciding on whether to intubate or not. But yes, even in trauma patients, when delayed intubation has occurred, patients have not. Even if pneumonia has increased, there has been no increase in mortality. So even if there is pneumonia, can not be a major clinical outcome. We have to look into short-term and long-term mortality. Even if it is pneumonia, I think it is fairly treatable, and GCS should not decide. It should not be correlated with an outcome like pneumonia.
Yeah, Manju, if you are there, do you think that it has been long enough we should come out of the clutches of our condition of like GCS to fear the judgment about it, to be judgmental about pneumonia, or would you stick to it?
Sir, absolutely. I agree with that. While GCS is one criteria, we should always look at the chance of aspiration. If we look at the type of poisoning patients that we have, we get more of organophosphorus poisoning. That is or any other insecticide. That is much more common. Then comes antidepressants. Now, organophosphorus, as it is, has a problem that it can increase the secretions as well as it can cause respiratory failure. So that means that patient needs intubation. Somebody who is prone to respiratory failure, having plenty of secretions, we have to intubate the patient. Whereas when I worked in UK, what I came across, most of them have opioid poisoning and alcohol intoxication. They will be intubated in the ED, but by next day morning, they will be fine, and most of them gets extubated and goes out of the ICU. So the profile of patients is different. So we have patients who are more prone for aspiration. So that is the more relevant thing.
Well, that also depends upon the nature of the coma, because organophosphorus poisoning all may not have coma, but yet they may be sick enough to be intubated. But that besides the
Anirban,
point.
if I can add, Anirban, just Pradeep here. I think Manju made a very valid comments, because see, if you look at the profile of the poisoning in this study, they are not very relevant to our Indian context. That's a very beautiful point Manju has made. And I agree, we don't look at GCS, Anirban. Even here, if patient is protecting airway, there's no pooling of secretions, pretty much you know that they would recover. If there is, obviously it's a clinical acumen possibly that is needed before you intubate. Per se GCS, if someone is very pleasantly dozing off after an alcohol binge, maybe you may not jump and into. So there is some clinical acumen that needs to be put in place rather than an isolated GCS number, if that's what we are discussing, Anirban.
Even in France, I don't think that they won't jump to intubate a patient right after alcohol, because then half of the country would get
Anirban, no. Manju Matthews has made a very valid point, because even in Australia, where I was, people get intubated overnight and they get extubated the next day. It is just to save the hassle
of not able to restrain. There is a lot of clauses as to when we can restrain, when we cannot restrain in the Western world. So they do intubate, Anirban, even though this is to prevent
So
other
in that
issues
case,
of
it's difficult to
restraining.
extrapolate. Yeah. I
Yeah,
get
sir,
your
Yeah,
point.
yeah.
sir, can I just say something? See, in India, I've seen in Chennai as well as in here in Kerala, if somebody is intoxicated, alcohol, they lie on the roadside. Nobody is going to call the ambulance or the police because we think, okay, they are possibly intoxicated. We just leave them like that. No, even if the police come, I don't think they take them to a hospital. Whereas there, the police will take them to the hospital, get them intubated, and next day morning they might just self-extubate because they just don't. They when they get the withdrawal, they'll just self-extubate and go. So it's that's one of the common cases in the ED.
Very, very, very true. Very true. And so it's probably difficult to extrapolate to situations that we encounter. But more importantly, those who have joined late, I just want to remind them that in this study, the intervention group that he was referring to is actually non-intervention. That is, withholding intubation was the form of intervention that was being mentioned while presentation of the study. I'm going to Jayaprakash once again. Jayaprakash, you think that the study, when they have actually done per protocol analysis and not intention to treat analysis, that also makes this study a weaker?
Yes, they need to, because that's why they use absolute reduction. If you will see that absolute reduction, many a study, if you will get it, sir. Sorry for my voice, I'm not feeling well. So if you will see that there are many a study where we are using risk reduction, sometimes risk reduction ratio. So in that sample size, if you will calculate that, because in one slide, the presenter showed the 7.8% it was. If you will go through that analysis, you will find this is very different. See, this is a very tricky thing. The statistician, how they are interpreting their data, that is also important, because on all those meaningless number, we are giving meaning to our paper. So though if you will see that, this is that's why I told very clearly, but they are very big people, they can easily publish their paper in some hi-fi journal. But coming to your question, sir, what you asked, can you repeat again, sir?
Yeah, I was asking you about per protocol analysis against intention to treat analysis. They have done here per protocol.
Yes. Actually, they have to use, but it was in limitation. But they didn't mention in clearly limitation. But if you will go in that methodology section, they mentioned it. But in limitation, it was hide.
Shashwati,
Yeah,
if you have,
Anirban, if I can just add one point to allude to JP. So I may differ from the initial statements. I know I may be devil's advocate that this is just like an observational study. Actually, there are a lot of limitations in this study. This is because people who have worked in the West, like Manju Matthews, we know that this is like an observational study where you would not intubate certain patients, because the authors do mention there was a Hawthorne effect, which means there was a change, there was modification in the behavior, which is very much likely that has happened because the study was happening, it was unblinded. So there are huge problems. This is, for me, when I read that cursorily, it appeared like an observational study which they have converted into randomized, made some jargon and tried to publish in a very good journal. So I would look at it with the critics optics, Anirban.
Fine. So if I ask, go to Shashwati to ask that, what if you have to reproduce this study in your setting, what would be the major changes that you'd first likely to make and then try to reproduce this study against what the authors have done or the investigators have done in terms of patient selection, in terms of randomization, or in terms of exclusion criteria, or in terms of intervention?
So I think it is going to be a very big challenge to even think about reproducing this study over here.
That's true.
Yes,
And
so,
to get permission from the ethics committee will be even bigger.
Just waiting to intubate a patient who has come unconscious might be extremely difficult in a busy emergency department. The logistics might be different. But I think in the inclusion criteria, we would or in the exclusion criteria, we would probably need to, apart from patients whom they have already excluded, the knowledge about the poison might be very important, and especially if somebody like an OP poisoning has come, like Dr. Manju was already mentioning, who is drowning in the secretions. So obviously that will be because in their exclusion criteria, they do not include these kind of things. Probably they don't face these kind of issues in that situation. So those kind of criteria will be important apart from only GCS. So just having a GCS number, but there will be some additional criteria which will need to be clubbed with the GCS as an indication for intubation. I think that would be the first thing.
Absolutely. I fully agree to that point. Shulagna, if you see the study and you find that they have also done this study in patients without taking any consent because of the absence, because of the emergency nature, and went on to take a delayed consent. It's a different question, but in our setting or in Indian scenario, is it permissible, or would ethics committee mind if you doing that, if you subject the patient to the study and take on consent at a later stage and submit the ground that this was an emergency where consent was difficult or close relative was not available?
Sir, consent, if it's an emergency and if it is a standard treatment, we can go ahead with it. But if this is not a standard treatment, then without consent, I don't think it will be acceptable in our scenario. And I mean, I have, as far as I have come across, it won't be doing a experimental thing in a group of patients without consent. In our setup, when we don't have a relative to give consent, we often call for the bystander or the police personnel. They can give consent on behalf of the family person. But doing a
in real life scenario, any police person any doctor would ask a police person to give consent for participation in a study, or in that case would they respond?
Yeah, that is for very standard things, like we inform we are intubating or anything which is life-saving and standard, but not for a I don't think it will be acceptable for a study scenario.
Yes, sir, in this study it was clearly mentioned that next to kin consent was taken from next to kin, because this is
before that
all
kin
cases were from acute comatized patient. So definitely it was mentioned clearly that, and all patients were age group of more than 18 years. There was no confusion in this one for this paper.
No. If you see the line before, other than those who are not next to kin was not available, those were brought to the emergency team or by police or whosoever. In those cases on emergency patients, that was delayed consent was also there. Anyways, besides the point, I go on to Pradeep. Are you there? Okay. If Pradeep is not there, I will go to Shashwati.
So what happens if at a delayed stage, the relative or whoever is he withdraws the consent? So then I think the power, I mean, the sample size differs, and I think it's not a very good idea to do it.
No, I'm not talking about the intervention. I think in order to enroll anybody for any study, you need a consent. Whether the intervention or no intervention comes at a later stage. But if you enroll and later on he says that he's not giving consent, then obviously you will have to remove him from the list.
Yes.
Yeah. And if it's an intention to treat analysis, you will have to analyze him as well. Because once the randomized always. So anyways, Kabi, since we are already running out of time, and I will, before I go on to each of the panelists about their 3 important messages which can come out from this study, I want to ask Shashwati about one last question about when you see the criteria that they have used for emergency criteria, which they used as any seizures or respiratory distress or fall in saturation below 90%. They have also mentioned, do you think that this list of 4 conditions was adequate, or they have left out quite a number of other conditions which would have also come under that criteria of emergency criteria for intubation?
So I think a lot of other criteria would also be important. Seizure, vomiting, both of these are okay. But respiratory distress on nasal cannula, saturation less than 90, and the other one, the shock after 1 liter of crystalloid resuscitation. Apart from that, the amount of secretions, a lot of other criteria will need to be a part of the criteria for emergency intubation.
Absolutely.
And we have already mentioned a lot of these poisoning patients may have a suspicion of trauma as well. So those are the things, whether there was any additional factor which could contribute to the level of consciousness. So those would definitely need to be the criteria for intubation.
Fine. So now, before I will give one last question to all the panelists. I will ask if Pradeep is there. I will start with Pradeep. Pradeep, are you there? Dr. Shorin? Or then I will move on to JP. That what are the 2 or 3 most important messages which comes out of this study? Yes, JP.
Sir.
You can enumerate 1, 2, 3. Yeah.
Yeah. By this study, we can first, we should also proceed for this kind of a study. What Saraswati ma'am said that we have very limitation. Definitely, we are most populated country in the world. One thing, and our scenario, our tertiary care center even are not facilitating same kind of, because they are getting time, especially for research purposes also. But we are not getting. Second thing, coming to the point that, see, once, if you will, sir, one more thing I would like to add here. If you will see the exclusion criteria, that is also limited. So by this study, you may proceed, but this you may withhold the intubation. But this totally depend on your clinical judgment. When you have to wait, which kind of patient you are admitting, what the in coming half an hour, where patient will land up in ICU or not, because all these patients were from emergency department. In our scenario, the patient directly coming in ICU through ward if any patient is deteriorating. So this is totally depend on the clinical, and every person having their own clinical judgment.
Okay, fine. Dr. Manju, if you are there, would you like
to give? I'm not going to give any clear-cut message, because everyone having, yeah.
Yeah, Dr. Manju, you are there?
Yes, sir.
Yeah, Manju, 2 or 3 most important messages that comes out of the study that you think?
So first thing is, it's extremely difficult, we all know, to conduct studies in these kind of areas where whether intubation is required or not. In India, we will not get consent for these kind of studies. At least in my institution, it's extremely difficult. They'll ask a lot of questions. It's one thing, I think, but what we can do, the same thing we can do as an observational study, maybe retrospective or prospective, because we have lots of different types of ICU. We are not just, we have hospitals with ICUs, we have hospitals without ICUs, we have government setups where naturally intubations don't happen. So if we take a number of hospitals and do a observational study, I think we will get some data to go with. But randomizing is extremely difficult, and the topic per se, it's very difficult to blind the study also.
Shulagna, 1 or 2 points quickly that comes to you after reading this study.
Sir, I think the intervention group, as Dr. Pradeep mentioned, had because of the Hawthorne effect, they had intensive monitoring and follow-up. And I mean, that this is not a pragmatic thing that we can conduct. So in our scenario, of course, the study is not feasible. But yes, I completely agree with Dr. Manju. And maybe, with different type of toxins, as different type of presentations, we can
probably observational studies makes more sense. That's what you mean to say.
Yes, and observational study, and we can stratify the patients depending on their the etiology of poisoning. And maybe we can especially nowadays we are getting a lot of heavy metal poisonings from in and around Delhi. So those patients often have toxic encephalopathies mainly, which have borderline GCS and may not require intubation, and they have other therapies which can act quickly. So maybe in certain subgroup of patients, we can conduct some small pilot studies, and we can find out from big observational data which subgroup will benefit the most.
Arjun, what was the most important thing that you have learned from this study?
This study included a lot of patients with alcohol intoxication. So I think in the Indian scenario, first of all, as ma'am said, these patients will probably not even end up in the hospital. So the question of intubating or not intubating them would not come. And probably these patients who are intoxicated but don't come to the hospital, most of them survive without intubation. So that itself would probably tell us that it might be a good option to not intubate them and to not be very aggressive in our treatment.
Shashwati, your last message from you.
That GCS should not be the only criteria which will decide intubation. We have to take into account the other issues before we decide whether to intubate, especially if it is an alcohol intoxication.
Yeah, there is one from the audience. Poonam Arora has raised her hand. If she has any question, I will request her to unmute herself or Vinay to unmute her so that she can ask. We are all staying there. This is the last question that I'm going to take before closing. Yeah, Vinay, can you allow Poonam Arora to unmute her too so that she can ask her question? Since she has raised her hand, but she has not typed anything in the chat box.
Am I audible?
Yes.
Good evening, sir. So this is Dr. Poonam Arora from AIIMS Rishikesh. Sir, I wanted to add something. Like you said that is this study possible in Indian setup? Like intubations, I disagree with this comment that in government setups, intubations are not happening. Like in training institutes all around, intubations are happening. They are taught this thing that these are the indications you need to intubate for these indications. The study can be modified, like it can be made observational study. And instead of withdrawing intubation, like that intervention which they have done, we can do that. We can see which patients are being intubated for what reason. Like drowning in secretion, especially in OP poisoning, and fear of occlusion in dynamic airway like corrosives. This study can be modified like that.
Very valid point. We can see the cause of intubation, and finally we can, when we have a large number of patients in different scenarios, different poisonings, we can see and compare the outcomes. Outcome can be anything, can be a composite outcome or can be a single outcome. It doesn't matter. So friends, that brings us an end to this very important journal club discussion, and we can conclude that although the study looks very attractive outwardly, and we all feel that it carries a very fantastically attractive to think that not intubating a patient carries as good as prognosis than intubating it, but probably there are very loops of corners we have to understand and again think of twice, because all the factors that limit or delimit this process of extubation and intubation should be clearly defined and understood till the time. So till we are back again for a new episode of GICS Journal Review, from all of us in the news desk, and my special thanks goes to Dr. Shashwati and her team, as well as to all the panelists present here. And till we join again from next Friday with more interesting journal club, from all of us in GICS Rapid Journal Review, thank you, Shubharatri, Shabar Khayat, and good night.
Thank you, Anirban. Thank you, Sulagna. Thank you, Jay Prakash. Thank you, Shashwati. Thanks, everyone.
Thank you.
Thank you so much.
Thanks, everyone. Thank you.
Bye.